இல்ல இல்ல சித்திர கிளாஸ் ஸ்டார்ட் பண்ணலாமா?
Yes, ma'am.
Good evening to all. I welcome all the PGs and the faculties and friends and colleagues for this PG case discussion classes conducted by Tamil Nadu Federation TNFOG as Bodhana PG case discussion. This is our fourth PG case discussion class. We are conducting this class every month, second Saturday and fourth Saturday from 5:30 to 7 or 7:30. So for this, now we have the coordinator, Dr. Kalpana. She will be coordinating the entire program. Dr. Kalpana, stage is yours. And I welcome the teachers, Dr. Paraniyappan, Dr. Shanmugavadivu, Dr. Tenmuri, and Dr. Hema. Due to some reason, Hema is not there. We can manage. Kalpana.
Introduce Kalpana.
Kalpana Irkia.
Okay,
Kalpana is
good evening, everyone.
fertility consultant in Guru Hospital. Kalpana is a present secretary of Madurai Society, and she is a course director for postdoctoral fellowship in endogyny and academic profile. She has given many lectures and invited guest lecture in national and international conferences. Awards to her credits are Best Doctor Award by Dr. MGR University, Medical Excellence Award 2018 from Governor of Tamil Nadu, Best Medical Service Award from Madurai District Collector, and Golden Excellence International Award by European Continental University. Welcome, Kalpana. Kalpana, you can take over.
Thank you, ma'am. Good evening, everyone. This wonderful initiative by Sampath madam and Anjalakshi madam and TNFOG team. This has been very successful over the past few months. Actually, this is our successful fourth PG initiative, and this program would be really helpful for the exam going PGs. And we have excellent teachers who can share their knowledge and experience, which would be really helpful for the PGs. For this program, we have experts, internal examiners, Tenmuri madam. Can we have their profiles, Priya, Chitrakala? First of all, I would like to welcome Sampath, Anjalakshi madam, to deliver welcome address for this wonderful program. Can I have Anjalakshi madam? Madam is a founder president of TNFOG, past president of OGSI, governing council member of DIPSI. She has done PhD in diabetes in pregnancy under MGR Medical University, recipient of Best Doctor Award from IMA, retired professor OBG from Madras Medical College, presented number of papers in national international conference, research work in GDM diagnostic test and OHA in GDM, original work on single test procedure for the diagnosis of GDM, followed in guidelines of Government of India, endorsed by WHO and FIGO. Over to you, madam. Anjalakshi ma'am.
Hello.
Yes, madam.
Hello, am I audible?
Yes, madam.
Kalpana?
Yes, madam.
Okay. Dear colleagues and my dear students, postgraduates, it is my pleasure to give the welcome address. And today is our fourth program of Bodhana. I think it is benefiting the postgraduates. A request to the postgraduates, I want them to give the feedback at the end of the class. So we'll do something to get the feedback. We'll just discuss and tell you. And now I welcome the teachers par excellence, Dr. Tenmuri, the internal from our Chennai, and externals, Dr. Shanmugavadivu, and
Madam,
the
join,
teacher par
ma'am.
excellence, Dr.
Yes, ma'am.
Paraniyappan.
Welcome.
Hemava?
Shanmugavadivu madam வந்துட்டா join பண்ணிட்டா. Yes madam.
Shanmugavadivu and Dr. Palaniyappan, the teacher par excellence. For you people, know you are blessed. And the topic today is the heavy menstrual bleeding, which is the commonest problem when the gynec OP, more than 40% of the people, they come with the menstrual abnormalities. And there are a lot of confusions and modifications in the definition. And we have the form coin now, which gives some clarity regarding the classification of the heavy menstrual bleeding. So I request all of you to have a good discussion and clarify all your doubts. I welcome once again all the teachers and the students for this program. Thank you.
Thank you so much, madam. I invite internal examiners, Tenmoli madam, who is associate professor in Bodhi, Chengalpet Medical College, with 15 years of teaching experience. Madam has presented many papers in national and international journals. Welcome, ma'am.
Yes, madam.
We have Shanmugavadivu madam also as an examiner. Madam is an associate professor, GMKMCH Salem, graduated from MMC Chennai in 2006, working in GMKMCH since 2006. Madam has been trained in ultrasound and laparoscopy. Madam's interest is in high risk obstetrics. Welcome, ma'am. The other examiner is Palaniyappan sir, who is a professor and unit head in the OBG, Sri Ramachandra Medical College, Chennai. Sir has won Indumati Javari Award in 1994 and Young Scientist Award in 1996, A.L. Mudaliar Traveling Fellowship in 1998, Senior Overseas Fellow, Liverpool Hospital, Sydney, and he was a Kamnirao Orator, Young Gynecologist Awardee of TNFOG in 27, invited speaker at various national and international conferences, and author of many chapters in textbooks. Interested in high risk obstetrics, joint organizing secretary of AACOG 2015 Chennai, President OGSI 2020, chairperson of Safe Motherhood Committee 17 to 19. Welcome, sir. Now I welcome our Thirumagal, final year PG, Chengalpet Medical College, as a presenter. Sampath madam and TNFOG had prepared a welcome medal for the presenting PGs, so that it would really encourage the presenter. Madam, you want to tell something, Sampath madam?
Only like this, Thirumagal, this medal will reach you by courier. Okay.
Thank you, ma'am. Thank you, ma'am.
Okay, நல்லா பிரசன்ட் பண்ணினாதா, நல்லா பண்ணலன்னா கொடுக்க மாட்டோம். Okay, okay, welcome, welcome.
Now I invite Dr. Thirumagal to present her case.
Ma'am, shall I start screen sharing, ma'am?
Yeah, please. Dr. Thirumagal,
Yes.
please kindly share the screen.
Good evening, ma'am.
Please go to slideshow.
Yes, ma'am. It's in slideshow, ma'am.
Slideshow.
Slideshow. Shall I start, ma'am? It's in slideshow.
நிமிஷம் திருமகள் டாக்டர் பழனியப்பன் அண்ட் டாக்டர் சண்முகவடிவு ஒரு லாகின்லயுமே 4-5 பேர் இருப்பாங்க பசங்க. திருமகள் கூட இன்னும் ஒரு 4 பேர் இருக்காங்க. திருமகள் அவங்க பேரையும் சொல்லிட்டு ask questions. Okay,
you introduce all of them. Show in the video.
பேர் மட்டும் சொல்லிட்டீனா அவங்களுக்கு கேள்வி கேட்க ஈஸியா இருக்கும்.
Yes, ma'am. I'm Thirumagal, third year OG-PG, ma'am, Chengalpet Medical College. This is
Dr. Kavita, third year OGG, Chengalpet Medical College, ma'am. Dr. Kristi, final year PG, Chengalpet Medical College.
And today my case presentation is about heavy menstrual bleeding. I'm presenting this case under the guidance of Dr. in Chengalpet College. Kate, 45 years old, para to live to
அம்மா ஸ்லைட் ஷோக்கு போனோம். திருமகள் 1 minute ஸ்லைட் ஷோக்கு போனோம். ஸ்லைடு தெரியல, மூவ் ஆகல.
நெட் கனெக்ஷன் கொஞ்சம் இதா இருக்கிற மாதிரி இருக்கா?
இல்ல அவளோட நேம் தான்
இருக்கு மேம்.
இல்லம்மா ஸ்லைட் ஷோல
slide is not visible. Next slide.
ஸ்லைட் ஷோல இருந்தா சைடுல தெரியாது.
நெட் கனெக்ட் ஆயிருக்கு.
தெரியுதுங்களா
மேம் இது ஸ்லைட் ஷோல இல்ல, you can just go to அங்க இருக்கு பாருங்களேன் ஸ்லைட் ஷோ அனிமேஷன் பக்கத்துல அத கிளிக் பண்ணுங்க.
இந்த 90% பக்கத்துல ஒண்ணு இருக்கு பாரு, அத கிளிக் பண்ணினா ஸ்லைட் ஷோ போய்டும் திருமகள். கீழ 90% தெரியுதுல்ல, அது பக்கத்துல ஒண்ணு கப்பு மாதிரி ஒண்ணு.
எஸ் மேம்.
வந்து
இல்ல மேம் என்னோட லேப் ஸ்லைட் ஷோ.
yes ma'am, now it is seen.
அதுதா மேம்.
ஓ ஸ்லைட் ஷோ வரலன்னா பரவாயில்ல. ஓகே டாக்டர் பழனி, can you see this?
So sorry to interrupt ma'am. Chitrakala ma'am.
Yes,
மேம் ஒரு வாட்டி ஸ்டாப் ஷேர் பண்ணிட்டு நீங்க எந்த பிபிடியும் கிளிக் பண்ணாம எந்த ஐகானையும் கிளிக் பண்ணாம ப்ளூ கலர் ஷேர் அமுக்குங்க மேம். ஸ்டாப் ஷேர் பண்ணுங்க மேம்.
ஓகே மேம்.
ஸ்டாப் ஷேர் பண்ணிட்டு இப்ப ஷேர் கிரீன் கலர் ஷேர் ஐகான் பிரஸ் பண்ணுங்க. நீங்க எந்த ஐகானையும் கிளிக் பண்ணாதீங்க. நெக்ஸ்ட் ப்ளூ கலர் ஷேர் ஐகான் கிளிக் பண்ணுங்க.
ஓகேவா மேம்?
இப்ப ஸ்லைட் ஷோ போடுங்க மேம். எஸ் மேம், பெர்ஃபெக்ட் மேம்.
Ma'am, Mrs. K, 45 years old, para to live to, residing at Nandivaram, homemaker, belonging to socio-economic class 1, came presenting complaints of heavy menstrual bleeding for the past 1 year. History of presenting illness: she was apparently normal 1 year ago. Then she had excessive menstrual bleeding for each month. Regular cycle, huge amount, soaps 8 to 9 pads per day, associated with passage of cloth, associated with abdominal pain. History of taking medications for decreasing the bleeding. No post-coital bleeding, intermenstrual bleeding. No history of excessive white discharge per vagina. No history of constipation, hair loss. No history of heat intolerance, diarrhea. No history of excessive weight gain, hair growth. No history of bowel or bladder disturbances. No history of easy bruising, delayed wound healing, gum bleeding. No history of chest pain, breathlessness, palpitation. No history of chronic drug intake. No history of weight loss. No history of fever, evening rising temperature. Menstrual history: attained menarche, 14 years of age.
Tirumagal, sorry to interrupt. I thought we finished off each one of them. So why are you so bothered about postcoital bleeding, intermenstrual bleeding? Why are you worried about white discharge and a heavy menstrual bleeding? Go back to your previous slide.
Bleeding, we should think about cervical malignancies in polyp, submucous fibrosis.
Tirumagal, go to the previous slide, Tirumagal. Please go back to your previous slide. Yeah, go on. Yeah. So postcoital bleeding, why are you bothered?
Suppose bleeding, if it is specific, and think about submucosal fibroid polyp, CSX, endometriosis is in the cervix or in the vagina, or an atrophy of vagina.
Or it could be a cervical polyp.
What are the differential diagnoses to say for this? Say some of the differential diagnoses.
Of atrophic vaginitis, ma'am, cervical polyp, fibroid, C6, endometrium, endometriosis in the vagina.
Okay, fine. Excessive white discharge is because of CA cervix, you said. Okay, cold intolerance, what are you wanting to say there? Your slides are not visible there, Tirumagal.
கனெக்டிவிட்டியே போயிடுச்சு. செங்கல்பட்டுல தான் ஹெவி ரெயின் இல்ல, அதனால கொஞ்சம் யோசிச்சுட்டே தான்
உங்களோட
இருந்தேன்.
கனெக்டிவிட்டி ரொம்ப பூரா இருக்கு மேம்.
தேன்மொழி அவளுக்கு ஒரு ஃபோன் பண்ணேமா.
So பண்றேன் மேடம்.
Is there any other PG from somewhere where they can present the same case?
கவிதா
Thirumagal is coming.
இல்ல ஒருத்தர் தான் பிரசன்ட் பண்றாங்க செங்கல்பட்டுல இருந்து.
இதுக்கு ஆன்சர்ல மேம்.
So வந்துட்டா Thirumagal has come. Yeah, go on Thirumagal. Why are you bothered about cold intolerance, constipation and hair loss? Cold or heat intolerance is because of?
I think her audio is not coming. Dr. Kavita, are you available?
திருமகள் அன்மியூட் பண்ணுமா.
Thirumagal unmute பண்ணுடா.
Any other PGs available, Dr. Kavita?
Ma'am, கேக்குதா மேம்?
கேக்குது சொல்லு.
Hyperthyroidism, there can be cold intolerance, constipation, ma'am. Heat intolerance, diarrhea. We'll think about hypothyroidism.
Okay, fine. Okay, excessive weight gain, hair growth. ஒன்னொன்னா கிடுகிடுன்னு சொல்லி முடிச்சிரு.
Excessive weight gain and hair growth, we have to think about high estrogen conditions of in AUB, ma'am. So for PCOD, I've taken excessive weight gain. Patient can have high estrogen secretion.
Fine.
And hair growth for hirsutism PCOD.
Fine. Okay. And easy bruising and delayed wound healing, bleeding.
That is for the coagulation disorders, ma'am, to rule out any coagulation disorder.
Fine. Okay. So what chronic drug intake will you think in terms of Dr. Kavita?
Kavita.
Any aspirin, heparin, antiplatelet drugs.
Okay.
Then antipsychotic drugs also will cause.
Fine. So all those drugs can cause heavy menstrual bleeding, right? And we also need to think in terms of the back pain, etc. at the age of 45, 46, whatever, 50, and they go to an orthopedician and they very slowly they will give alendronate, bisphosphonate, and sometimes even estrogen creams and estrogen tablets, which can also produce bleeding in a lady like this. It may be postmenopausal or it could be a lady with perimenopausal age group. These women will have back pain and they go to an orthopedician. Without we knowing, the orthopedicians will prescribe these drugs and they can also produce bleeding. So we need to be aware of that. And people from somewhere near the Thailand, Malaysia, Singapore, if you see, they are very good in taking the soya milk. The drink which they have is soya milk, and the isoflavones and soya milk will produce estrogenic stimulation and can have an endometrial hyperplasia and they can bleed very heavily. If you want to take soya milk drink, which is very healthy, but in a perimenopausal or a postmenopausal women, if they take the isoflavones in the soya milk can produce a bleeding tendency and they can have more bleeding tendency. So these are drug history or the personal history which you want to add, you can add. Okay, fine. Weight loss, you're thinking in terms of diabetes, is it?
Wait. Diabetes.
Dr. Christie, answer. Diabetes, what happens in diabetes?
Cancer. Weight loss can be
weight loss in diabetes and cancer. Okay, fine. Okay, fine. So evening rise of temperature and fever can happen in tuberculosis. Fine. Okay, you can go to the next slide. Change your slide and go on.
Menstrual history. Moderate flow, uses 3 to 4 pads per day. No history of menorrhea, passage of clots. She had profuse bleeding for the last one year. Her LMP was marital history, married since 25 years of age, non-consanguineous marriage. Past obstetric history, para to live to, both full term normal and delivery. Last childbirth 20 years ago. History of puerperal sterilization done 20 years ago. Contraceptive history, no history of any contraceptive usage. Last is not history of diabetes, hypertension, bronchial asthma, epilepsy, thyroid disorders. No history of previous surgeries except puerperal sterilization. No history of chronic drug intake. Family history, no history of family history of gynecological malignancies. No history of bleeding diastasis in family. Personal history, consumes mixed diet, not a smoker, alcoholic, normal bowel and bladder habits. General examination, patient afebrile, pala, mild pala present, no pedal edema, not ectric, no hirsutism, petike, no lymphadenopathy. Height 156 centimeter, weight 60 kg, BMI 24.4 kg per meter square. Pulse 100 by pulse rate 92 beats per minute, respiratory rate 16 per minute. Systemic examination, CBS, S1, S2 here, no other sounds, normal other sound. Breast examination, normal. Examination, no tire enlargement. Examination, normal. Examination, equal realization, earlier free. Sinuses, very visible pulsations, no obvious mass in per abdomen. Enlarged size,
next slide change pannuma. It's not coming. Change the next slide.
Uterus enlarged 14 days, regular, smooth, non-tender, firm and consistency, side to side mobility present, lower border not palpable, no free fluid, no other organomegaly. Percussion over the mass, dull note here over mass, no fluid shifting or shifting dullness. Auscultation, vowel sounds present.
Madam.
Pelvic examination, external genitalia normal. External genitalia normal, first speculum examination, vaginal walls healthy, cervix healthy, no abnormal bleeding or discharge per vagina. Bimanual examination, cervix regularly enlarged to 15 weeks, limited mobility present, bilateral fornices free, rectal examination, rectal mucosa free, no summary, 45-year-old, previous to normal vaginal delivery, LMP 11-3-21, with presenting places and bleeding per vagina, with menstruation with heavy menstrual bleeding for past 1 year, managed medically on and off with general examination revealing anemia, and parabdomen and pelvic examination revealing a mass of 14-week size, firm and consistency with transmitted mobility. Provisional probable diagnosis, Mrs. K, a perimenopausal multipara women presenting with heavy menstrual bleeding for past 1 year with dysmenorrhea, and pelvic examination revealing a uterine enlargement of 14-week size, probably adenomyosis or leiomyoma of the uterus.
Okay, Tirumali, why do you want to say with your diagnosis after doing PV, adenomyosis or leiomyoma?
So by vaginal examination, I have to differentiate between an ovarian and uterine mass. I have to see the size of the uterus, which is enlarged to 14-week size. I have to see for transmitted mobility from the cervix, whether the mass is moving with the
But I thought you did that. You said there is transmitted mobility. So it's a uterine mass.
Yes.
Now, why do you want to say in your diagnosis either leiomyoma or adenomyosis? Why can't you say one, either leiomyoma or adenomyosis?
It's most probably adenomyosis because it is regularly enlarged. But leiomyoma can also have firm consistency with when it is small and 14-week size.
No, even a leiomyoma can have a regularly enlarged uterus. For example, if there is a single huge fundal intramural myoma, uterus can still be enlarged to 14 weeks. I mean, a regular enlargement need not be irregular. Still, it can be leiomyoma. Would you want to support your statement and say these are the findings in adenomyosis, these are the findings in leiomyoma?
So adenomyosis has specific features.
It will be regular.
Yes, that is
regular. It will be a tender and a tender mass. Tender mass with it will be less. It will be soft tender mass generally. So it will not be firm as in leiomyoma. Leiomyoma will be generally irregular with firm consistency, non-tender mass.
What is consistency in adenomyosis?
Meiosis, it will be soft. Generally, it will be soft to firm consistency. Not. hard consistency.
Tirumagal, fibroid can also be soft in consistency. It can undergo degeneration, isn't it? Yes or no?
It can undergo degeneration.
So it can undergo degeneration. It can be hard if it undergoes calcareous degeneration. It can be soft if it undergoes cystic degeneration, isn't it? Yes or no?
Yes, say yes.
Yes,
Okay.
sir.
So what will be your differential point with your adenomyosis? See, you can go back to your history and see whether the patient has got triple dysmenorrhea, and it will be very tender. Okay. Whereas your leiomyoma, it will be non-tender when you do a PV, and you may not have triple dysmenorrhea. You may have dysmenorrhea. You may not have triple dysmenorrhea before, after, during periods. So with that, you will be able to say, but anyway, I agree with you. The point is you may have to distinguish between these two. And how would you want to distinguish? What is your first line investigation you want to do?
I will do a complete count for this patient.
Excuse me, what is
And
the
we would,
necessary investigation? Necessary investigations
To
other than the
differentiate
routine
between the
investigation.
two, I would like to transvaginal sonography to differentiate between adenomyosis and fibroids.
Fine. So how would you differentiate between an adenomyosis and a fibroid uterus?
What is the features in ultrasound?
In adenomyosis with the transvaginal ultrasonography, there are 8 characteristics and use. To increase, there will be distances in the endometrial myometrial junction. Either it can be a uniform enlargement or it can be a focal.
செங்கல்பட்டுல நெட் கனெக்டிவிட்டி பெரிய ப்ராப்ளம் நினைக்கிறேன். இன்னைக்கு நல்ல மழை. டாக்டர் பழனியப்பன், அவங்கள வந்து நம்ம வீடியோவை கட் பண்ண சொல்லிடலாமா?
வீடியோ கட் பண்ணிட்டு ஆடியோ மட்டும் வர சொல்லலாமா?
ஆமா, பெட்டர். திருமகள்,
அப்ப கால் பண்றேன் மேடம்.
வீடியோவை கட் பண்ணிட்டு ஆடியோல ஆன்சர் பண்ணுங்கப்பா. கொஞ்சம் சேவ் ஆகும் நெட் கனெக்டிவிட்டி.
Ma'am, okay. Yes, ma'am. Ma'am, கேக்குதுங்களா மேம்?
கேக்குதுப்பா, you continue.
கேக்குது. யார் பேசுறது?
Adenomyosis with the user classification, ma'am. We can say this as focal adenomyosis or a regular enlargement of the endometrial myometrial junction, or it can be a stick mass beneath the endometrium. It can be a fan-shaped.
நாலு பேரும் ஒரே இதுல லாகின் பண்ணா இதான் ப்ராப்ளம். தனித்தனியா பண்ணியிருந்தா கொஞ்சம் பிரச்சனை இருந்திருக்காது.
மேம், இன்னொரு இதுல லாகின் பண்ண சொல்றேன் மேடம் நானு.
அதான் வேற இதுல வந்திருக்கலாம். ஏன்னா இன்னைக்கு கனெக்டிவிட்டி எனக்கு காலையில இருந்து கொஞ்சம் பிரச்சனை, யோசிச்சுட்டே தான் இருந்தேன். சண்முக படிவு, நீ கொஞ்சம் லைட் போட, முகமே தெரிய மாட்டேங்குது.
லைட் போட்டிருக்கேன் மேடம்.
சரி, நோ ப்ராப்ளம். வந்துட்டா, திருமகள் வந்துட்டா.
கேக்குது திருமகள், go on.
Adenomyosis in ultrasonography, sir, and we will like to classify it with the MUSE classification. It can either be an regular enlargement of the endometrial myometrial junction. It can be a focal adenomyoma, fan-shaped shadowing. It can be cystic masses beneath the endometrium, or it can be a irregularity in the junction or interrupted endometrial myometrial junction. While fibroid, it will be a we will have a world appearance, well-defined borders. We can also shade it with the use of Doppler. There will be intra-lesional flow in adenomyosis, while the fibroid.
Palaniappan sir, you have to unmute. Dr. Palaniappan, unmute. Kalpana Palaniappan sir, unmute பண்ணோம்.
Palaniappan sir, you have to unmute, sir.
Yes. Okay, Thirumagal, my question is now, how would you want to distinguish between these two on an ultrasound, you said? My next question is, would you at some point of time do a MRI or CT to confirm adenomyosis from a fibroid, or you're happy with the ultrasound? Ultrasound is definitely the first line investigation, agreed. If there is a chance, or is there a possibility that at some point of time you should do an MRI or a CT to distinguish between the two? What are the occasions?
The endometrial myometrial junction is well visible in an MRI rather than an ultrasound. So to see the extent of the adenomyosis, to distinguish the small fibroids which are less than 3 cent, which may not be visible in transvaginal sonography. I will like to do with adenomyosis with fibroid. I will like to do an MRI, sir, to see the.
Fine. So you're not wrong. At some point of time, you may have to distinguish between the two. If you're planning on a myomectomy or an adenomyomectomy for these patients, then probably you need to map the fibroids first with ultrasound. But if you have an adenomyoma, you may not get a very clear picture, and you're not wrong in doing MRI. Whereas in our old days, when we were doing PG, if we say MRI, our chiefs will blast us. But today, it is not wrong if you say MRI to distinguish between the two, so you're still fine. Okay, so you could do MRI, and there is something else in the MRI which you will pick up. For example, if you have an extrauterine adenomyoma, for example, in the pouch of Douglas, a rectal adenomyoma, etc., you will not be able to pick up on an ultrasound. So if you have a pouch nodule, which you can feel as nodularity, which you mentioned in your clinical examination, that will be picked up by a MRI rather than an ultrasound, right? So these are all the places where an MRI is more sensitive to pick up than your ultrasound, which you usually do for your adenomyosis. Okay, fine. So having said that, you would classify this as palm coin A, isn't it? AUB, HMB, palm coin A, and we would distinguish between L and A. Having said A, now let me ask you, what is the discrepancy or deficiency of this palm coins classification? It's a beautiful classification, no doubt. Is there a deficiency or a negative point of the palm coins classification? Leave alone fibroid and DUB. I mean, leave alone fibroid adenomyoma, adenomyosis. Generally, is there a deficiency of the palm coins classification of heavy menstrual bleeding?
Doesn't quantify the amount of blood loss.
Even in your DUB.
It is only the etiological classification, no palm coin.
What else, sir?
So what we cannot able to diagnose in case of palm coin when using palm coin alone?
செல்போன்ல லாகின் பண்றியாமா? கொஞ்சம் நல்லா வரும்.
செல்லுல லாகின் பண்ணுங்க.
நம்ம ஒரு 40 minutes முடிஞ்சிருச்சு கிட்டத்தட்ட. நாலு பேரும் தனித்தனியா கூட செல்போன்ல லாகின் பண்ணி ஆன்சர் பண்ணலாம். நிறைய டிஸ்டர்பன்ஸ் இருக்கே. சரி, ஆன்சர் பண்ணுமா திருமகள்?
She's not in the line.
Ma'am, கேக்குதுங்களா?
Dr. Christy,
Anyapan sir, you have to unmute, sir.
The Tirumagal.
சண்முகோடி கேளுங்க
இல்ல லைன்ல இல்லையே மேம்.
இருக்காளே
அம்மா சார் கேட்டது என்னாச்சுப்பா? What's the deficiency in palm coin?
There is any physiological thing is there in palm coin? So in adolescent PCOS, no, there is a threshold bleeding will be there, no? Is it mentioned in the palm coin?
Anovulated cycles, AVO, HPO access mentioned one.
That is one. The second thing is
Anovulated and ovulated. Irregular ripening and irregular shedding, it's not coming under this classification.
Then
the other point you need to say is, for example, if you're going to have a PCO or if you're going to have an endometrial hyperplasia, where will you put that? You will put it in HMBE, endometrium or ovary.
Both were the causes.
Palm malignancy and hyperplasia.
It is not it is hyperplasia.
It is only hyperplasia, no?
Right? So that is another
have a clear distinction.
Classification. You can put that as either O or E. So it is not very clear. So that is the disadvantage of the palm coins classification, because it's not very clear. But having said known the deficiencies, we put it as either O or E you want. That is one. And the other thing is anovulatory AUBs are not included in it. So these are all the deficiencies of the palm coins classification. Right? Fine. So now having this, let us say that it is adenomyosis, right? That is what the case looks like. Yeah, Dr. Tenuri.
Yes, madam.
Right. Now, what is that? This lady you have diagnosed adenomyosis, ultrasound has been done, and that looks like an adenomyosis. So what do you want to do?
What is her age? What is her age?
So this patient, I have locked cell phone, sir. So this patient is in the perimenopausal age group. So first, I would like to rule out other causes of AUB. Like to do a thyroid function test, bleeding time, clotting time, coagulation profile, CBC, LFT, RFT, transvaginal ultrasound to see the endometrial thickness. Then I'll do an endometrial biopsy. See if the endometrial thickness is increased, I will do an endometrial biopsy, sir. For the management, if it comes out to be a normal endometrium with adenomyosis, ma'am.
Excuse me, only in case of endometrial thickened, you
More
want to
than
do
how much
biopsy.
endometrial thickness you will do endometrial biopsy?
Ma'am, for a post, if it is a post-menopausal woman, I will look for, I will do an endometrial biopsy if it is more than 5 millimeter. As this is a premenopausal woman, the cutoff varies with the menstrual cycle. I give the cutoff of 14 mm, ma'am, 12 to 14 mm.
So she is 45 years. Okay, only in case of endometrium thickened, you want to do endometrial biopsy, or you want to do endometrial biopsy in this age group. That is the question.
Ma'am, for a woman with presenting with 45 years of age group with SP, endometrial biopsy, ma'am.
So your patient, what is the age of your patient?
45 years, ma'am. 45 years with HMB, I will do an endometrial biopsy, ma'am.
Yes. Okay. When you plan to do a endometrial biopsy?
Endometrial biopsy at any women presenting at 45 years of age with HMB, I will do an endometrial biopsy. If less than 40 years of age, if she is having endometrial thickness increased, or if she is in estrogen prone condition, increased estrogen conditions like PCOS, obesity, diabetes, if she is having any increased estrogen factors, I will do an endometrial biopsy. Or in HMB, which is not responsive to medical management, I will do one biopsy. If I'm
Tirumagal, you can't put a patient on medical management without doing endometrial biopsy. The question is, when will you do your endometrial biopsy? Which phase of the cycle will you do?
Which phase of the cycle?
Which phase of the secondary phase I will do an endometrial biopsy.
So how you
So you will do it Premenstrual, isn't it? So that is what you should say. This lady, I thought her LMP was 3 months back.
What is her LMP?
Yes, sir, that's when I took the case, so it was at the time. She is bleeding
Fine.
continuously.
So
for
now
1
she's
year.
ready for doing endometrial biopsy, isn't it? So anytime you
Yes,
can
sir.
do an endometrial biopsy now because it is 3 months now her LMP. So you could do an endometrial biopsy. So what is your idea of doing an endometrial biopsy?
So if it is I have to rule out hyperplasia or malignancy in this patient, sir, for deciding my management.
Okay.
So only
But having said adenomyosis, no, but having said adenomyosis, still why are you bothered about malignancy?
Sir, there can be malignancy with adenomyosis or fibroids, sir. Endometrial carcinoma can be associated with fibroids or adenomyosis, sir. That's 3% chance. No, sir. Both these conditions can be present together, sir. She's a 45 years
that is the
old,
answer.
so I want to
Yeah.
rule out.
Okay, fine. So both of them can coexist, isn't it? So that is the reason why you would want to do a endometrial biopsy. Agreed. Okay. So having said that, both of them can coexist. Won't you be able to pick that up by an ultrasound? By thickness, isn't it?
Sir, but endometrial hyperplasia. Yes, sir. We can, if it's ET will be increased in both conditions, sir. Malignancy we can
Fine.
differentiate with irregular borders, everything, sir. But hyperplasia it will just present as increased endometrial thickness, sir.
Fine. Okay, agreed. So
So
that is
I
agreed. So I
correctly
take that
confirm my
point.
diagnosis with biopsy, sir.
Correct, but also beware and don't go give the opinion to the other PGs that for all adenomyosis, I will do an endometrial biopsy. That is not what is required, right? Okay, so having, what do you think the endometrial biopsy report will come? If the report comes as secretory phase, what does that mean?
What is your plan of management?
If it comes as secretory phase, what is your plan?
It is an ovulation.
Yes, but she is having heavy bleeding, no? She's having heavy bleeding,
Yes,
yeah?
ma'am.
Then
Yes, ma'am.
Fine, because ovulatory. Okay. Okay, Thirumagal, agree. Just give the answers clearly. If it is going to be ovulatory DUB, agreed. So she's secretory, so she's ovulatory. What will be your treatment of this particular lady?
Sir, patient is. I will correct the anemia. I will first stop the bleeding with symptomatic management for stop bleeding with traffic or restroom. Then I will go for correct the anemia with the according to the CDC, I will correct the anemia with oral or IPI. In the concurrent time, I will medical management, sir. If medical management cease, I will go for hysterectomy with starting hysterectomy.
Why? We're going for directly. Why you are directly going for hysterectomy?
No, in the concurrent time, I am going to try.
Not audible. Not clear.
Thirumagal not continuously audible. Disturbance, more disturbance were there. What about your medical management? Talk slowly, na? It is not audible clearly. It is not audible, ma.
Ma'am, is it audible now, ma'am?
Not clearly audible.
Yeah. Okay.
Not clearly audible.
Sir, am I audible now, sir?
No, not clearly audible, ma. Log in from some other cell phone.
வீடியோவை கட் பண்ணிட்டு பேசுமா வரோம் சொல்லு கூகுள் ஆன்சர் பண்ண
Ma'am, ma'am, patient has failure, ma'am. First, I will do investigations. According to the CBC, I will plan my management, ma'am. If the CBC is low, I will first I will stop the bleeding with tranexamic acid regestrone, correct the anemia, and concurrently I will give medical management for this patient, ma'am, to decrease the size of the adenomyosis and symptomatic relief. If medical management
What medical
fails, then I
management
will
will
go
you
for
give?
hysterectomy.
What
Sir,
medical management?
Tirumagal, what medical management will you give? If the endometrium is secretory phase, what medical management will you give? Let us forget adenomyosis for some time, okay? If the endometrium is secretory phase, what will you give?
Sir, I will go for GnRH analogs.
Oh, is it? Why GnRH analog? She's ovulating. That is ovulatory TB, which is normal. Secretory phase of the endometrium, and there is no adenomyosis.
No adenomyosis. I'll give for tranexamic acid, sir.
Only tranexamic
How long?
acid is enough.
Tranexamic acid or regestrone at
Progesterone, why?
progestins.
So you want to give progesterone.
Progestins.
So every second half of the cycle, you mean from the 13th day, 14th day, you will give progesterone.
Medroxyprogesterone acetate for
Dosage.
second half of the cycle alone I will give, sir. For 10 to 13 days from 15th day to 26th day. I will give.
What is the dose you will
But what
prefer?
is your side effect?
Ma'am, dose is 10 mg per OD for 10 to 13 days in the second half of the cycle. Side effect is progesterone. There can be intermenstrual bleeding, bloating sensation, weight gain.
So you can't give them long.
Flush.
That cycle, yes, Tirumagal. You can't give them oral progesterones for a longer period of time. Is there anything else which you can give? Can't you give OCPs for this lady?
OCPs, sir, I can give OCPs for symptomatic relief.
It's only secretory phase.
Yeah.
So
Or else
everything
I
is
can
normal.
Yes, sir. OCPs
So
will
give
regularize
OCPs.
the cycle.
Regularize the cycle. You can't give only progesterone for a very long time. So give her oral contraceptive pill with low dose estrogen. That will take over the entire cycle and will control the cyclical bleeding, right? Okay. If the biopsy report comes as proliferative phase, first is secretory phase, you finish. If it comes as proliferative phase, what does that mean?
Proliferative phase.
First I will reduce the acute bleedings with tranexamic acid and progesterone. Progesterone I can start from the day of 15th day, sir. Progesterone and MPA will give from 15th day, sir, so that the progesterone secretion it will decrease the endometrial proliferation and cause shedding of the endometrium. Or else I will go for an LNG IUD, sir. If it
Fine.
is an,
So this is a condition where you can give LNG IUS or still go ahead with your OCPs, isn't it? OCPs you can't give longer, 6 cycles, whatever, or you can go ahead and give LNG IUS. Not a bad choice to give LNG IUS, isn't it? So this is an ideal case to give LNG IUS. Okay, fine. So that is about the proliferative phase. If the report comes as endometrial hyperplasia without atypia, with atypia, what will you want to do?
So endometrial hyperplasia without atypia, considering her age, sir, it is 45 years. I would like to give progesterone for 3 cycles. I will repeat the endometrial biopsy after 3 months. I'll be repeating endometrial biopsy after 3 months until 2 negative values are obtained. If it is obtained, I will repeat it after 6 months. If it is persistent, I will go for hysterectomy.
But if you're putting in an LNG IUS, you want to do a biopsy along with the LNG IUS?
Yes, sir, we can do a biopsy with LNG.
You will pull out the, then that means when we're doing a biopsy, you will pull out the LNG IUS.
Yes, it's with LNG also we can do biopsies. Hello, sir.
Yep. So would you want to remove the LNG
No,
IUS
sir.
or then how would you take a biopsy? That's my question.
So with the LNG in situ, with the adequate dilation, I can do and biopsy.
You
Sir.
don't have to repeat your DNC or a biopsy, ma. When you put an LNG will be worth for 5 years. You can just measure endometrial thickness. You have taken an biopsy just now only, and then what happens is, for your hyperplasia to progress to malignancy, it takes a very long time. So you don't have to repeat your biopsy every 3 months with the LNGIUS. It can stay in for 5 years. For systematic management, we can explain to the patient that she comes to you with your HMB and how her symptomatic relief is there. That is what you have to see. There is no idea, no point repeating your endometrial biopsy every 3 months and 6 months. What is the percentage of endometrial biopsy, endometrial hyperplasia going into malignancy?
5%.
Without
in what number of years?
5%, sir.
Without ATP, with ATP.
With what? How many years?
5 years. 5 years.
5 years?
3 years, sir.
Messing up with the percentage, Thirumagal.
Sir, it's 5%, sir. I don't know, number of years.
Okay,
3
fine.
years,
So
sir.
anyway, check. I'm not going to tell you that that's your homework. So it is very, very rare to turn malignancy, especially when a patient is on progesterone. That too, your local progesterone, which is LNGIUS. LNGIUS has been graded very well for your hyperplasia, and there are enough recommendations by the RCOG also to put LNGIUS even for grade 1 endometrial carcinoma, stage 1 grade A endometrial carcinoma, isn't it? So till then you can give a LNGIUS. You don't have to repeat your biopsies very often. In India, probably we will not do that when you think in terms of malignancy. So you can use your LNGIUS till that point of time, right? Okay, so next is, when you have a atypical hyperplasia, what is your choice of treatment?
So considering her perimenopausal age, I will suggest a hysterectomy for this patient, sir.
Fine. So now is when you can debate between LNGIUS versus your hysterectomy for this particular lady. We'll come to hysterectomy at the end of the class. Okay, fine. So this is how you will go on with your endometrium. And so this is AUBE. We've almost completed. Now let us go on to your AUBA. Dr. Shanmugavadivu, you want to ask any questions in endometrial E? Endometrium, you want to ask anything else?
So why you go for hysterectomy in case of malignant atypical hyperplasia?
Ma'am, the
chance of malignancy
is 25 to 33% with endometrial hyperplasia with atypia, ma'am.
Okay, then there may be you are just taking a biopsy, so there may be a coexisting endometrial carcinoma also.
Yes, ma'am. Yes. Yes, ma'am.
Fine. Okay. So that is one. And if it's a case of adenomyosis, then what will you do? We'll come back to our original case of adenomyosis. We finished AUBE. If it's going to be AUBA, adenomyosis, then what will be your choice of treatment?
This patient is 45 years. She is in the perimenopause. She has anemia. So I have to first stop the bleeding with tranexamic acid and progesterone. I will stop the acute bleeding. I will correct the anemia. I will try medical management for this patient with the GnRH analogs or aromatase inhibitors with add-back progesterone therapy. If my medical management fails, I will go for a hysterectomy, sir. Hysterectomy with salpingo-oophorectomy.
Why not LNGIUS? You are going for a more costly treatment with GnRH analog.
Ma'am, LNG produces symptomatic relief, ma'am. GnRH will give concurrent added benefit of decreasing the size of adenomyosis. Hence.
No, I don't agree with you, Thirumagal. So you will give LNGIUS for how long? 5 years?
So if the symptoms are relieved with LNGIUS, for 5 years till she so that within the time if she attained menopause and symptoms are relieved, I will give LNGIUS.
Fine. I don't agree with you for your GnRH analog. So what do you think are the advantage and disadvantage of GnRH analog? I thought even before you said GnRH analog. So how much of GnRH analogs are you using? You mean to say Lupride?
So Lupride 3.75 mg monthly dose or 11.53 monthly dose we can give, maximum of 6 months.
How long?
So maximum of 6 to 12 months, sir.
That's all, isn't it? So you mean to say your adenomyoma will regress in 6 months?
Yes, sir. If it regresses,
Okay, fine.
symptoms are relieved, then.
Agreed. No, symptoms will go on when you give Gina channel lock. After stopping therapy of 6 months, what will happen to your adenomyosis?
So after 6 months, it will again recur, sir.
Then what is the big point of giving Gina channel lock, such an expensive drug?
Yes, sir.
And also in the perimenopausal age group, what else it can cause when you are giving long-term gene channel lock?
It will cause a state of pseudomenopause, ma'am. It will cause bone loss.
Osteoporosis. It can increase osteoporosis.
Yes, ma'am. Osteoporosis.
Fine. So then why do you want to give that drug? It's of no use giving that drug, isn't it?
Yes, sir.
That's not a great idea to give Gina for this particular condition unless you prove fibroids and you want the fibroids to come down in size. That's a different story. Adenomyosis, Gina lock is almost a theoretical drug therapy. So you can't use it very often practically. So LNG-IUS is one of your choices, right? Okay. Next, you said if the LNG-IUS doesn't work for some time, then I will do a hysterectomy with BSO. Why do you want to remove BSO? Why do you want to remove those innocent ovaries at the age of 45 years?
Sir, she is in the perimenopause, sir. So
only perimenopause. So you want to make her menopausal, is it?
So
already you're removing the uterus. My question is, why do you want to remove the uterus at the age of 40? Ovaries at the age of 45?
So it will decrease the risk of ovarian malignancy or ovarian cyst. So I want.
So. Okay, so what is the incidence of ovarian malignancy? It is the same as what you and the other ladies in the whole CME are sitting there. It's the same risk as that. So why do you want to remove the ovaries just because you're doing a hysterectomy, is it?
So after hysterectomy, the blood supply to the ovary will also decrease, sir. So the function of the ovary will get lost will stop in within 2 or 3 years, sir. So
it will go on till 5 years. 5 years after a hysterectomy, if you don't clamp the ovarian artery very close to the ovary, right? So close, you clamp the uterus close to the medial end of the uterus. Then you can leave the ovary. She's only 45. Okay. We were talking about pseudomenopause and we were talking about bone mineral density for this particular patient. So please don't remove the ovaries, right? So there is no indication, and ACOG very clearly says routine removal of ovaries at hysterectomy at the age of 65. So please don't remove the ovaries. I don't agree with the point at all. If you have an ovarian cyst later on, we can always tackle it. For example, when we do an abdominal hysterectomy, so because ovarian cyst will come, you'll remove the ovary. Appendicitis will come, so you'll remove the appendix. You can have a kidney stone, so you can remove the kidney. So open up everything, combo pack, we remove everything and give them as a package. That's a good thing idea to do, is it?
Sorry, sir. No, sir.
No way. I do not agree with your ovaries removal at all. Never tell that in the exam. So you will never remove the ovaries at the age of 45. For normal looking ovaries, that's a different story, right? So don't ever remove the ovaries at 45 to reduce the risk of malignancy. And keeping one ovary, removing the other ovary, there is no role because one ovary can again become malignant. If at all it is going to become malignant, it is going to become malignant. Yeah, Dr. Shantirani is asking me whether to remove the tubes. It's a very good question. Yeah, remove the tubes. Tubes is almost a vestigial organ after the, that increases the malignant potential of the ovaries. So remove the tubes. So your answer should be hysterectomy with bilateral salpingectomy, right? Okay. So having said hysterectomy with bilateral salpingectomy after doing your Mirena or LNG IUS system, yes. So you will do, what will be your route of hysterectomy for this particular patient?
Sir,
for your patient, think of the parity, size of the uterus.
Yes, ma'am. I can do, ma'am. The ovary is 14. The uterus is 14 week size, ma'am. So I'll go for. I will do a vaginal traction test. I will look whether there is no fornical fullness, no adhesions in the uterus. If there's no adhesions, then I can go for a vaginal hysterectomy, ma'am. If the Valsalem traction test is positive, or I will go for a laparoscopic hysterectomy, ma'am.
Yes, Thirumagal, you're perfect. So I like your answer. So you will do a Valsalem traction test, and if there is descent, or even if there's no descent, you can still go ahead and do a non-descent vaginal hysterectomy. Adenomyosis is a little difficult than a fibroid to do an NDVH because you will have a gritty sensation while you core the uterus, whereas a fibroid will just come out beautifully with your capsule, and so it's fine. And you can still remove the tubes through the vagina. If that is what somebody is going to ask you next, would you remove the tubes through the vagina? Yes, I will remove the tubes through the vaginal route. So vaginal NDVH with bilateral salpingectomy is a good answer. But if you have a doubt, if you are not very confident, you are not wrong in saying that you will do a laparoscopic hysterectomy. So you will put a laparoscope from above and remove the uterus from below, because she's a para 2 live 2 and uterus is only 14 week size, just above the pubic symphysis. So it's perfectly fine. So you're not wrong in saying either an NDVH or an LAVH. And if in a place where I don't have laparoscopy and no expertise, you are absolutely not wrong in telling I will open up the abdomen and do a TAH and a bilateral salpingectomy. So absolutely. So route of hysterectomy will depend upon the surgeon's expertise and what the patient wants. Of course, the best of the route would be a vaginal route, followed by laparoscopy, followed by abdominal, right? Is there anything else, Dr. Shanmugavadivu, Dr. Thelmuri, you want to add anything else to the route of hysterectomy?
No, sir. No, sir. We'll proceed. We wanted to say conservative surgeries for adenomyosis.
Yeah, just coming to it. Is there anything else? If this lady was 35 years old and she's not 45 and she's not willing to remove the uterus, she says my menstrual function is lost. So what other surgeries would you do on a patient who's only 35 years old with adenomyosis? Yes, Tirumagal, Christy, Kavita, anybody can answer.
Minimally,
Kavita.
Minimally invasive surgery I will try, sir. That is transcervical resection of endometrium, otherwise roll baller endometrial ablation. In the second sitting, this laser endometrial ablation, balloon cavertrum therapy, and trans balloon inflamed ablation therapy.
No, see, don't go on answer like a theory question, because that is what is given in your textbooks. What will you do? If you have the setup, what will you do? What is your choice of the endometrial ablative procedures?
Transcervical endometrial ablation.
Okay, so you will do a TCRE, fine, okay. So you will do a TCRE, but what is that you're thinking in terms of TCRE in a 35-year-old lady? She's got another 10 years or 15 years of menstrual function. You're leaving the uterus, you will rule out malignancy, and then you will do an endometrial ablation, agreed. So you will do a first generation or a second generation endometrial ablative procedure, whichever is available in your hospital or whatever. Fine, but what do you expect out of this lady? What do you expect out of the procedure? You mean to say she'll have amenorrhea?
We can stop the amenorrhea, but endometrial thickening we should consider the fertility of the patients also. If she is desired to fertility, this
you will not do the endometrial
ablation is the contraindication.
Correct. Ablation is a contraindication. I said 35, para 2, live 2. She's delivered 2 children. She's 35 years old. So now what do you want to do with a 35-year-old lady who's completed family? So you can still do ablation. What am I asking is, what do you expect out of the procedure? Are you expecting amenorrhea in all patients by doing an endometrial ablation?
And 30% will get amenorrhea. Some will get heavy menstrual bleeding also after that of the procedure.
Then there is no point.
So I will try instead of the ablation. LNG IUCD is there now.
Okay, Kavita, we have finished LNG IUS and we've come to ablation now. Let me tell you that when the ablative procedures came into picture 15 years back, people thought that it will be a good reduction in the rates of hysterectomy. But the hysterectomy rates did not come down after the ablative procedures for the very simple reason, endometrial ablation did not produce amenorrhea in all the women. 25% of all the patients who underwent endometrial ablation had recurrence of symptoms, right? And 25 of them had hypomenorrhea. Only 50% of them had amenorrhea, if that is what you expect out of the procedure. But the amenorrhea patients, after 3-4 years, when the base layer of the endometrium regenerates, they came back with symptoms, right? So this is what happened when Goldroth in the US and the other person in the UK did the endometrial laser ablation versus the TCRE, and I'm going to tell you about the mistletoe trial, which came long back. And they said, whichever you're comfortable with, you can do either the second generation or the third generation ablative. But said all and done, none of them proved to be very efficient for the management of heavy menstrual bleeding. And so not many people still follow doing the endometrial ablative procedures. And so you need to keep in mind that if you choose a lady at 47, 48 who's going to undergo menopause, and you do a endometrial ablation for her, yeah, you're spoiling the basal layer and the functional layer also. So that is a lady who will benefit, and not for a lady who's 35, 40, because they will regenerate their basal layer and they'll come back with symptoms. And so you can't get, so that is the patient choice, which you have to make a good choice and then choose the endometrial ablative procedures. I agree, your cavaterm, your radio frequency ablation, all of them have come as OP procedures now, but all of them have their own disadvantages of symptoms coming back. And so you may not be able to say that this patient is going to be happy about it. So that is the disadvantage of endometrial ablative procedures. Is there anything else you can do for adenomyosis? What is the role of adenomyoma resection? When will you do adenomyoma resection?
If the patient wants to conserve her fertility, and if the adenomyoma is well circumscribed adenomyoma of less than 10 centimeter, then I can go for an adenomyomectomy for this patient. For not for this patient, for a patient who wants to conserve her fertility.
Right, agree. So there is a role for adenomyomectomy, which we were doing 20 years back, then it went off and now it's come back again. And I'm sure the fertility surgeons do a lot of adenomyomectomy to preserve fertility. You can do it open or you can do laparoscopically. Agree. Okay, then now my next question is, if you have adenomyoma and you have a spot on the laparoscopy here and there on the peritoneum, then what will you look for more? So you're doing a laparoscopic hysterectomy. So you put a laparoscope and you're able to see an adenomyomatous uterus.
Sir, hello, sir. Sir?
When you have endometriosis along with adenomyoma, what else you will look for?
So this, sir, I have to look for an endometrioma.
How will follow up?
Ma'am, endometriosis with adenomyosis.
Endometriosis with adenomyosis.
Ma'am, this patient, if it is a patient who wants to conserve her fertility, then during the laparoscopy procedure, I will do excision of the superficial endometriosis which were present, ma'am, and I will do an adenomyomectomy with during with laparoscopy, ma'am.
Okay, then how will you follow up? In post-operative period, what you give?
What else you want to give?
A post-operative will give progesterone. Ma'am, for post-operatively, we'll be giving progesterone for this patient, ma'am, to delay the recurrence of endometriosis. And as she is a patient who wants to conserve fertility, I will ask the patient to do an IUI ovulation induction with IUI immediately before she gets a recurrence.
Okay.
You have told the previously GnRH analog for adenomyosis. So in this case, it will be useful. So if you want to give GnRH analog, when there is coexistent endometriosis, you can try GnRH analog or you can try Diogest. Okay.
Yes, ma'am. Before laparoscopy, GnRH analog we can give and decrease the size of the adenomyoma.
After laparoscopy, when you plan for laparoscopy, when you plan for infertility or for other treatment and for a complete resection of endometriosis, you have to put her on a GnRH analogs. It will be more beneficial than that of the only progestages. Okay.
Yes, ma'am.
So if you are
when it is vaginal hysterectomy, you plan for a NDVH. No, when and all it is contraindicated. Non-distant vaginal hysterectomy.
Ma'am, when this patient has had uterus sterilization, ma'am, so when
not this patient,
when the uterus is not freely mobile.
Yes.
But when the uterus size is more than 12 or 14 weeks size, ma'am,
not
12 weeks,
the cutoff of 12 weeks, ma'am. Like that, more than 14 weeks. You say yes. 16 or
It's not matter of the size, no, what else you want to see more.
Then in the history of
Use freely mobile,
previous
ma'am.
history of
Must not be any additions.
previous history of
Ma'am, I'm not able to hear.
you say one by one. What are the points you
Ma'am?
have said? Yes.
Ma'am, the size should be less than 16 week size. The uterus must be freely mobile. Then there should be not be additions. No
We
previous
cannot
history
say
of.
there should not be any additions. Now, how we can say from outside that there should not be additions? So how we will rule out
The
whether there is addition is present or not? There should be no
size
previous
and
history of
mobility of the uterus should be
pelvic
present, ma'am.
surgeries. There should be
Yes,
no
ma'am.
previous
No pelvic
history of
surgery.
pelvic surgeries.
Yes,
Like that you have to say. Then
Yes, ma'am. The Valsalam traction test should be positive, ma'am.
so
The,
it just
when
need
they're
not
pulling-
it need not be there. No, Valsalva traction test need not be there. Sir have told no. In all cases, the Valsalva traction test need not be there. In anti-VHS is non-descent vaginal hysterectomy. You can do in a smaller size uterus in a previous vaginally delivered patients. Okay.
Yes, ma'am.
Okay.
So we move on to next one.
Ma'am?
What are the complications you will be encountering in the vaginal hysterectomy?
First, we'll start with anesthetic complications, ma'am. Then,
Sir have joined.
When you say specific surgery, surgical complication.
Surgical, there can be injury to the vessels, ma'am, bleeding, infections. Post-operatively, it can cause infections.
You know, intraoperatively, what else more commonly you encounter?
So it is non-descent vaginal hysterectomy. No, we will be injuring more adjacent substructures. What are
more common?
Injury to the ureter, bladder injury is more common. And rectal injury when we are doing a pelvic floor repair, rectal injury is common, ma'am. Perforation.
Thirumagal, don't go into wrong this thing. So you don't do a pelvic floor repair. Here there is no prolapse at all. Okay. So now my question is, you will injure the bladder more or you will injure the rectum more in an adenomyotic uterus while you're doing an NDVH? Which will you injure more? Sorry?
Bladder.
No, you will injure the rectum more. Your pouch of Douglas is usually obliterated in adenomyosis and endometriosis. Bladder interface will be free unless there is bladder endometriosis. Generally, it involves the pouch of Douglas. I'm sure you know that adenomyomas and endometriomas are more common in the ovary, followed by the pouch of Douglas, isn't it? So you will not be able to open your posterior pouch, and so you will be digging onto the pelvic fascia. So you will injure the rectum more than the bladder in an adenomyotic uterus when you're doing an NDVH. Okay? You got my point, Thirumagal? Okay, fine. So that is what you can injure. So you can injure this. The next question which I asked, you didn't answer. If there is a pelvic nodule and you're doing a hysterectomy, what will you do with the pelvic nodule?
So pelvic nodule, excision of,
it may be
remove the pelvic nodule, sir. Excision of the nodule.
Excision of the nodule is important. Otherwise, the patient will come back to you with symptoms. Okay, just adenomyoma. I'm sure you know that there are parabola-like adenomyomas. Okay, which extends into the pouch of Douglas and the posterior adenomyomas. It is not enough if you remove the uterus because you're doing only half the treatment. Patient will come back to you and say, "Doctor, you've done a hysterectomy. I've paid 1,50,000 whatever, and still my pain is not gone. I came to you for dysmenorrhea. Now there is no menstruation, but my pain is not settled." So she'll complain to you. So the pelvic nodule is something which is very important. You can use a rectal retractor called the Peter Maher's retractor, which is available. What the pelvic surgeons will use and the urogynecologists will use and the rectal surgeons will use. The nodule, the rectum, you put it into the rectum will bulge from above through the laparoscope. And you can do a nice wide excision of the nodule along with hysterectomy. So that is something which is important. And you can't leave the nodule just because we are not capable of removing. If you're not capable, we have to call somebody else and make sure that you remove the uterus and the nodule. Otherwise, they'll come back to you with symptoms. Okay?
Yes, sir. Yes, sir.
Sampath ma'am, inno evlo nero irukku ma'am? How much more time we have, ma'am?
10 more minutes.
Fine. Dr. Tenmoli
Yes,
Shanmugapadigo, anything more you want to ask?
Okay, sir. Proceed, sir. Enough.
Shanmugodi, Dr.
No, sir, adenomyosis.
No, I
that's
thought
all
we
I
can't
think, sir.
discuss.
We can go to.
I don't think we can discuss fibroid. We have discussed endometrium, we have discussed adenomyosis. இதுதான் பண்ண முடியும். Fibroid எடுத்தோம்னா இன்னும் 1 hour ஆகும், so we can't do.
The
So I want
fibroid
at
we
least
can
skip.
have separate class. Fibroid will be separate
Yeah.
class.
So separate class. Here we touched endometrium, we touched malignancy, we touched adenomyosis fully. We can't touch more than that. Anything more in this we will ask. Yes, questions you can ask Thirumagal, you can ask us, no problem. A choice is given to you now. Christy,
Not
Kavita,
only
Thirumagal, you can ask.
So
One minute, not
postmenopausal.
only Thirumagal, any PGs can ask your questions in the chat box.
So when there is a bleeding PV in a postmenopausal women, how will proceed? Postmenopausal bleeding, heavy menstrual bleeding.
Again, I'll do the routine investigations, ma'am. I'll do an ultrasound. I'll proceed for an hysteroscopy guided endometrial biopsy with cervical biopsy for an postmenopausal bleeding patient.
Then, so it says when it comes as a secretory endometrium, what you'll do? What is the most commonest biopsy that may come in postmenopausal women?
Secretary.
Then comes the
secretary.
Then comes then what is the commonest biopsy report?
Atrophic endometrium.
Then atrophic endometrium. Okay. What you'll do? How you'll treat the patient with the atrophic endometrium biopsy report?
Ma'am, I'll start the patient on HRT for this patient. Hormone replacement therapy.
Then hormone replacement therapy. Then we have to give what?
For symptomatic management,
it has to be overlapped with the progesterone. Always when you do estrogen, you have to overlap with the progesterone.
Yes, ma'am. Estrogen with progesterone.
Ma'am, any questions in the chat box, ma'am?
Thirumagal, what do you think is the advantage of a hysteroscope in this lady?
So,
what is your role as hysteroscope?
So, hysteroscopy can be both therapeutic and diagnostic and therapeutic for AUB, sir. Where I can do a concurrent biopsy for this patient. If there is a submucosal fibroid or a polyp, I will grade the if there's a polyp, I will do a hysteroscopic removal of the polyp. If there's a submucosal fibroid, I will classify it with the last mass classification, step W classification, and decide my management accordingly.
Fine. So that is your role of hysteroscopy in adenomyosis. Yes. So we discussed MRI, we discussed ultrasound, hysteroscopy, laparoscopy on an adenomyotic patient. And you also need to understand that if you want to keep a uterus for an adenomyotic uterus for fertility, if she's only 30 and she does not have children, then we need to plan an adenomyomectomy for her. That in that particular case, your laparoscopy will be helpful. So laparoscopic adenomyomectomy will be of much more help. And that lady has to be followed up immediately with fertility treatment. We can't leave a adenomyotic uterus inside, and so we probably have to do a IVF or whatever. So we have to plan her pregnancy immediately, because while leaving, one is her age factor, ovarian function, and two is her uterine adenomyomas can recur also. So we need to think in terms of making her pregnant as soon as possible, because you have kept the uterus only for that particular function. So do an adenomyomectomy, give a gap of 3 months, and then think in terms of fertility enhancing procedures, whatever it may be, whether it's IUI or IVF or whatever, right? So send her to a fertility specialist to make her pregnant as soon as possible, because that's the reason why you have left an adenomyotic uterus. The next question, last question, which I want to ask is, what is the percentage of adenomyoma with malignancy, uterine malignancy?
3%.
11% of adenomyomas can coexist with endometrioid carcinoma of the endometrium, right? So we need to be careful. And that is one of the reasons why I asked you a question some time back, you didn't answer that. So that is the only reason why we do an endometrial biopsy for all adenomyosis, because 11% of them can have a coexisting endometrioid type of adenocarcinoma. Right? So endometrial carcinoma. So you need to do an endometrial biopsy for all of them if you're planning on a fertility enhancing or a conservative surgery for adenomyosis. So that is the reason why you need to do an endometrial biopsy for adenomyosis. Okay. Yeah. Now you can ask your questions. We have another 5 more minutes. Any PGs can ask doubt.
One person have asked asymptomatic postmenopausal women with endometrial thickness 6.5. What we have to do?
Nothing. Leave her alone. She's asymptomatic, 6.5. Endometrial biopsy, endometrial thickness on a transvaginal ultrasound can be 6, 6.5, 5.5, and 5. It is like asking a goldsmith to make your kammal with 8 grams. It is not possible. It can be 8.1, it can be 7.9, 7.8. You can't make a goldsmith make 8 grams kammal. Can you do that with GRC Kazana jewelry? You can't do that. It's not possible. Same way, if I put the probe this way, it is 6. If I put the probe, it is like this, it is 5. So we need to do an endometrial thickness again. And if she's asymptomatic thickened endometrium, I will not do anything. I will just leave her alone, follow up, and go and do a biopsy and make her bleed. That causes more confusion. So you just leave it up and follow the endometrium. If she has a recurrence of symptoms, I'll probably put in a hysteroscope after that.
Okay, sir.
Okay.
PGs, I want you to ask questions. Yeah. How long after adenomyomectomy we can plan pregnancy? Is that what you're asking? Is that what she's asking, Sandhya Devi? Yes.
Yes.
The gap of 6 months for the adenomyomectomy to heal, because it's something like a myomectomy what you're doing. Yes. So after 6 months, you will plan a pregnancy, and that has to be fertility enhancing, whatever. That's what I said. Either IUI, IVF, whatever. So she has to become pregnant very well, depending on the ovarian reserve, male factor.
So how will plan for delivery, sir? In case of adenomyomectomy, we will be going through the.
She will be considered like a myomectomy, and we need to plan. She's already 35, whatever. You're probably in an IVF, so you have enough indications. Out of the 85% section, you can make one more cesarean section and say 86% section rates.
Yes, yes. Tirumagal, Christy, Kavita, any more questions, ma? You would have read.
Yes, Thirumagal. In spite of heavy rain, you have presented very well. Okay. Because of the connectivity, this is a problem. Other than that, you have presented well. But whenever this is not a PG exam, this is only a PG class. Okay. Whenever you present cases and whenever you give answers, first you think, what will you do in your place? Okay. If an examiner comes to Chengalpet Medical College and if you are going to present these cases, the first answer should not be GNRH. Okay? GNRH is not available in Chengalpet Medical College. Okay, wherever you are there, first what you are doing, be practical. Then you can go for the theory questions and answers, whatever it is. Okay? Thank you. Thank you very much.
Thank you, madam. Thank you, madam. We'll have a good experience, madam.
Yes, definitely. Thanks to Dr. Palaniyappan, who was
Thank you, sir. Thank you, sir.
leading all and Dr. Shanmugavadivu and Dr. Tenmoli and Dr.
Thank you, madam.
Kalpana, who was coordinating. Well presented.
Thank you, Sampath ma'am and Anjalakshi ma'am. That was a wonderful experience sharing with all of you. So looking forward to more such presentations and discussions with other medical colleges. I'm always on with Bodhana. Thank you very much.
Thank you.
More chance for other colleges also, ma'am. We can.
Yes, definitely. All colleges will be given. Till February, I have fixed. After that, from March, we can have.
Can have more frequent classes also.
I want more PGs to get involved. That's all. Okay. Thank you.
Okay, log in. Thank you, madam. Thank you, madam.
Thank you.